Okay, I think we are live. Let's just double check that it's going out onto the Facebook group. Check it's streaming. Yeah, we appear to be there. So no technical hitches so far. Amazing. Hello, everyone. Welcome to Weaning Week Day 4. We've got a really interesting day today based a lot around allergies and what to do, learning about allergies. And we've got the amazing Dr. Helen Brough with us today. She is a pediatric allergy consultant. Is that right, Helen?
Yeah.
And she's going to be talking to us all about allergies, and there'll be some time for questions as well at the end. I can guarantee we won't get through all the questions, but I'm hopeful that what Dr. Helen's going to talk to us about will answer a lot of your questions, and then we'll squeeze in some at the end. So Helen, do you want to tell us a little bit about yourself, and then I'll let you get going.
Great, lovely, and thank you so much for introducing me and for inviting me to speak today. I'm delighted to be here to give you the medical perspective on Weaning Week, and I'm hoping that I'll be able to answer a lot of your questions throughout my presentation, and of course very happy to answer questions at the end. So I'll go and share my screen. So this is where I work in my NHS practice. So I'm a consultant in pediatric allergy at the Evelina London, which is part of Guy's and St Thomas's Hospital. I'm an adjunct reader in pediatric allergy at King's College London, and that's where I do my teaching and my research. And then I do my private clinics at the Portland Hospital in Marylebone in London, and also on Wimpole Street. And what I'm going to be talking to you about today is focusing on food allergy, why it happens, and how you can prevent it in your baby through the process of introducing solids into your baby's diet. So let's see, hopefully this will go forward. Well, it's always the way, isn't it? I practiced it before, but it still is not moving. Let's see if I can do it with my cursor. Next slide. Okay, well, that's worked. I'll have to do it like that. So the learning outcomes for today are to understand how children become allergic to food. And there's actually a huge amount of evidence that's come out in the last 10 years about this. And then I want to summarize the current research results for allergy prevention, focusing specifically on food allergy prevention. And then I'm going to discuss the current infant feeding recommendations. So this is the first slide just to show you how common food allergy is throughout the world now. So England is there and the UK with 7.1% of children being allergic by 3 years of age. But you can see there are many places, North America, some places in the Middle East, many places in Europe, and some places in Asia, Southeast Asia as well, that have high rates of food allergy. This is the first slide, which will explain some of the reasons why children become allergic to foods. So this was a really big study done in Australia, and they looked at almost 5,000 children. They recruited them from their immunization clinics, so it was in the first few months of life. And they looked to see whether at 1 year of life, these children had developed food allergy or not. And they did that by actually bringing them into the clinic and giving them either egg, peanut, or sesame to see if they were allergic to these foods. They knew whether the child had had eczema when they were first included into the study. And they were able to show that if your child has eczema, that they were much more likely to have a food allergy. So that was for all food allergy, they're 6 times more likely, 1 food allergy, almost 5 times more likely, 2 food allergies, 11 times more likely. And you can see here for egg white, 6 times more likely, peanut, 11 times more likely, and sesame seed, 41 times more likely to have sesame seed allergy if your child has eczema. So why is that? Well, we know that eczema is the first barrier to the world outside in terms of the skin being disrupted. And we now understand a lot of the things that can mean that your child develops eczema. And that is the first step of what we call the allergic march, which is where you progress from one allergic condition to another. So we know that there are certain genetic factors. So in particular, there's a new genetic mutation that we now know about called the filaggrin mutation. Parents who have this mutation often have bumpy skin on the extensor surfaces of their arms. They may have eczema themselves. They may have some food allergies, hay fever, or asthma themselves. But there are other genetic factors. And we know, for example, with filaggrin, what that gene does is it provides the cement in between the bricks, which are the outer layer of the skin. And if you don't have that, then you don't have enough cement. And so what happens is that your child's skin is very dry. And then because it's dry, there are irritants and allergens and pathogens that get inside. And then it makes it not just dry, but also red and inflamed. This is what you can see here in the image. And some of the things in the environment that can damage the skin barrier are the various pathogens in the environment, so viruses, bacteria, and fungi. And we know, for example, that cradle cap is just fungi. And then what happens is that because the child hasn't got certain other proteins in their skin that help fight infections, those types of pathogens get deep-seated into the skin, and then they cause the skin to get worse. And I see a lot of children in my clinic who have eczema that's purely due to bacterial sort of contamination of the pots, because their parents putting hands inside the pot of ointment, which I would recommend not doing. And that's what's causing the child's eczema. Then peanuts in the environment. So a lot of my work, my PhD work, was looking at environmental exposure to peanut, and I'll go through that in my next slide. Now, we also know that detergents are not good for the skin. They're also not good for the gut in terms of detergents in the dishwasher, detergents in washing powders, but mostly detergents in the things that we're using to wash the babies. So it's very important to use, especially in a child that has dry or eczematous skin, a non-soap-based cream wash, so that you're not damaging the skin barrier further. So no bubble baths, for example. Also, there are quite a few creams that are marketed to babies that have a high pH. Basically, when you have a healthy, normal skin, the skin is actually usually quite acidic when it's happy. And if you put things that are alkaline, high pH creams onto the skin, what happens is that the skin gets broken down because some of the protective factors, like the ceramides, get broken down by certain things called proteases. So there's lots of things in the environment that can make the skin worse. Now, peanut, I talked about peanut in the environment. This was a study that was done a long time ago now. It was done in a big group of children, almost 3,000 children in Bristol. And they found that in the children that had eczema, 90% of peanut allergic children had had a cream containing arachis oil applied to them in the first 6 months of life before they were eating peanut. Now, thankfully, most creams do no longer contain peanut oil, but you can find other oils in many different creams which contain food. And there are still some creams, some nappy creams that contain peanut oil in them. So generally, I recommend against using oils containing food on the skin of children before they are regularly eating and tolerating that food. And I know that that is a bit of an issue because baby massage is a big thing in the UK. And a lot of the time they're using oils that contain food for the baby massage. So this is something which there's a lot of increased evidence going on looking at this. But for now, what I would suggest is only using proper creams for your child's skin and trying to avoid oils that contain food on the child's skin before they're regularly tolerating that food. This is the work that I did in my PhD, looking at what happens to peanut in the house. So we know that if you eat peanut now, today, for your lunch, in a sandwich, peanut butter or something like that, if I was to go to your home the following day, there would be a lot of peanut in your bed. And if you have a baby, you would have a lot of peanut in your child's bed as well, because the peanut gets spread around the house. So we know that if you eat peanut in your home, then you have a lot of peanut in the dust of your home. That was what I validated in my PhD. And we know that the peanut that's in the dust is biologically active and it has all the major proteins in it. We also then looked at two large groups of children, one in America and one in the UK. And we showed that if the child has eczema or that filaggrin mutation that I talked about before, then if they have a lot of peanut in the dust of their bed or play area, they have an increased risk of developing peanut allergy. So what are we going to do? We've got this situation where a baby has eczema. People eat a lot of peanuts in the environment now. What are we going to do to try and prevent this baby from developing peanut allergy? So now I'm going to move on to the next section, which is the theory behind allergy prevention and current research findings. So the change in approach to allergy prevention, where I've talked a bit about this slide already with the cutaneous exposure. We now know from various studies that children become allergic through the skin. So the skin is disrupted, dry and broken for various different reasons that I've mentioned already. And then you have certain foods going through the skin. And what happens is that the skin, which is angry and inflamed, see those foods like peanut, for example. They take them then to the lymph nodes and they start speaking to all the immune system and saying, this is something we need to fight. This is something we need to mount a response to that's going to get rid of it. And the type of response they provide is what we call Th2. And that gives you the allergic response, hives, swelling, etc. However, the alternative, in opposition to that, if you are exposed to the food through your gut, so actually eating that food, it goes into your gut, and the way that the gut sees things that are food is in a friendly way. So they say, right, this is something that we like, this is something that we're going to be tolerant to. So getting foods into the gut of the child is very important to promote tolerance. And this skin versus gut approach is called the dual allergen exposure hypothesis, which basically means that in the first year of your child's life, if your child is exposed to the food through the skin, they're more likely to develop an allergy to that food. If they are exposed to that food through the gut, they're more likely to become tolerant to that food. And that's where a lot of the research is building up. So this is a large study that I was involved with, which started in 2009. And this has really completely changed the way that we understand how to prevent food allergy. Now, the LEAP study, Learning Early About Peanut study, was a groundbreaking study which was run at Guy's and St Thomas's and King's College London. And we recruited 640 children in 2009 who were at high risk of developing peanut allergy. This was because they had severe eczema or they had egg allergy already. We know those two things increase your risk for developing peanut allergy. And they were then randomized into two groups. So at the time, in 2009, we were still being told to avoid peanut for the first 3 years of life if the family had a family history of allergy. This is now old advice. This has now disappeared. So at that time, that was the standard of care, and that's what we recommended for the children that were in the control group. So these children that we recruited between 4 and under 11 months of age were told to avoid peanut. Then the intervention group, they were advised to introduce peanut, not in tiny doses, but in high doses. So 3 heaped teaspoons a week of peanut butter from when they were recruited into the study until when they were assessed for peanut allergy at 60 months or 5 years of age. They then came into the trial, clinical trials unit at the Evelina London, and we did food challenges to peanut on all these children. And what we found was that in the group that were avoiding peanut, 17.2% of them had developed peanut allergy, whereas in the consumption group, only 3.2% of these children had developed peanut allergy, which is over 80% relative reduction in peanut allergy, which is huge. And in fact, when you looked at the groups that were able to do this intervention, the consumption group that were still allergic were allergic because they were already allergic at the beginning of the study. They were already allergic by the time they got into the study, so they couldn't introduce peanut into their diet. If they were able to do that, the efficacy was almost 100%. So there were lots of questions that were raised after the LEAP study was published. So the first thing was, is it effective? And they showed that yes, it definitely is effective. Then they asked, is it feasible? You know, is it possible for a child to continue to eat that much peanut over the first 5 years of life? And yes, in fact, the average amount of peanut that was eaten was more than the amount that they asked them to do. Children generally really do like peanut butter. Then there were concerns about choking episodes. And what I would say is that actually globally, given that many people know about this research now, there was this huge intake of peanut being consumed. In the LEAP study, there were no choking episodes as whole peanuts were avoided. But now we know as things have gone very wide and there's been less medical supervision or education about this, that some families were giving their children tiny bits of peanut. And that is obviously a choking hazard and should be avoided. So whole peanuts should be avoided until the child is 5 years old. But yes, so that was the feasibility. And then they were worried that if you introduce peanut into the child's diet at 4 months, or even at 6 or 7 or 8 months, are you going to reduce the amount of breastfeeding? These children, many of them were being breastfed. And they actually looked at that, and there was the same duration of breastfeeding in both groups. Then they were worried about the fact that peanut does contain a lot of protein and a lot of fat. Were we giving these babies all this extra protein and fat too early? And actually they found that there was no difference in the weight, length, or the fat stores in the children when they were assessed at 5 years of age. And in fact, what they found was that peanut was being used as a healthier snack rather than crisps or other sort of sugary drinks. So it was a benefit for the diet. So these are the conclusions for the LEAP study. They show that early introduction of peanut, mention again, so smooth peanut butter, not whole peanuts, in children with severe eczema or egg allergy significantly reduced the risk of peanut allergy assessed at 5 years of age. They found that giving them 2 grams of peanut protein 3 times a week, which is 3 heat teaspoons of peanut butter, was safe and feasible every week. There was no negative impact on growth, nutritional intake, or breastfeeding duration. And what they did, which was very clever, was that they then asked the families, all families, to stop giving their child peanut for 12 months to see if this protective effect continued, and it did continue. So they got re-challenged again at 6 years, and they were, for the large part, apart from a few, had maintained the same level of tolerance to peanut. So that's peanut. But then what about all the other foods? So we did another study in the same clinical trials unit, Guy's and St Thomas's and King's College, London. This was called the EAT study, inquiring about tolerance. And this was, if anything, a bit more controversial. Back in 2010, and when it was started, it was even earlier introduction of food. So this group was the general population. They asked to recruit 1,303 exclusively breastfed infants. And then at 3 months of age, they either advised that they continue to exclusively breastfeed until around 6 months of age, which is the current Department of Health guidance, or they asked them to introduce food allergens early from 3 months of age. That included cow's milk, hen's egg, fish, sesame, peanut, and wheat. What they then did was that they assessed them at 1 year of age and at 3 years of age to find out whether early introduction of these foods could prevent the development of food allergy to these foods. So what did they find? So I'm going to focus on peanut and hen's egg because they were the most important findings, because they were far more common allergies than, for example, the wheat allergy. So in the left side of the slide, you see something called intention to treat. That basically means that it doesn't matter whether you did what the study investigators asked you to do or not, you still get included in the arm that you were meant to be in. And what we found in the EAT study is that because we were asking them to introduce 6 different allergenic foods under 6 months of age, some families found that very difficult, and some babies found that very difficult as well. So overall, when you had a large group of children who didn't manage to do it, there was a benefit, but it didn't quite reach, statistical significance. So, for example, peanut allergy went down from 2.5% to about half, 1.2%. And for egg, it went down from 5.4% to 3.7%. But in the groups that were able to introduce the foods, there was a 100% reduction in peanut allergy. And for egg, there was a 75% reduction in egg allergy in the early introduction group. So introducing peanut and egg from 3 months of age. They then did some modeling to see what was the minimum amount that you needed to give the baby to be able to have a effective intervention. And what they found was that the baby needed to have 2 grams of protein. So that's 1 small cooked hen's egg per week. So that could be spread over the week, or 1/3 of an egg 3 times a week. And the minimum amount of peanut was 1 heaped teaspoon of smooth peanut butter, which would be mixed in with other foods per week, or 1/3 of a teaspoon 3 times a week, which is quite doable. So, summary of results for the EAT study. They showed that if the children were able to consume the minimum amounts required, particularly for peanut and egg, then there was a significant reduction in food allergy, particularly to these foods. What they found is that in children who were at high risk of developing peanut and egg allergy, actually, for all the study, even if they did or didn't do the intervention, there was a significant prevention of peanut and egg allergy. They also looked at the same concerns about growth, feeding difficulties, and breastfeeding duration and extent, and there was no negative impact of this intervention on breastfeeding, because that obviously was the major concern, given that they were starting solids from 3 months of age in this group. And since then, they've done a large study, which has looked at both the LEAP study and the EAT study and other studies. And they look to see, when is the good time to introduce peanut into the diet. Now, they looked at different groups based on how likely that child was going to develop peanut allergy. What they found from the LEAP study and the EAT study is that if you had more severe eczema, you were more likely to develop peanut allergy. If you had a longer duration of eczema, then you were more likely to develop peanut allergy, which is probably because of exposure through the skin. And also, if you had non-white ethnicity, you were more likely to develop peanut allergy. So they grouped this into the very high risk group, the high risk group, medium risk group, and the low risk group. You can see here that overall, if you were in the low risk group, introducing peanut from around 6 months of age gave you a pretty similar benefit to doing it at 4 or 3 months of age. So for the low risk group, introducing peanut by 6 months of age is fine. However, if you then go to the very high risk or high risk group, you can see that even down from 3 to 6 months, there was a big drop in the efficacy of introducing peanut into the diet. So for example, in the very high risk group, if you introduced peanut from 3 months of age, it was a 60% reduction in peanut allergy. If you introduced peanut at 6 months, it was around a 35% reduction in peanut allergy. So you weren't getting much reduction in peanut allergy, because the child was already too far along their way to becoming allergic to peanut. So what does this mean for us? What does this mean for us with infant feeding? What I thought I'd first do is give you a bit of background on complementary food introduction. Complementary food is sort of just to stress that when we introduce solids into the diet, we don't want to be stopping breastfeeding. It's always alongside breastfeeding. So we're not weaning off breast milk. We are continuing breastfeeding with the addition of complementary foods. So in 2000, if you look at how many children had introduced solids by 3 months, it was actually 24%. And in 2000 also, 85% of parents had introduced solids into their child's diet. After 4 months of age, was only 15%. If you look at the reverse, so in 2010, so closer to what we're doing now, 5% were introducing it by 3 months, 30% by 4 months, and most were doing it after 4 months, 69%. You can see here how things have dramatically changed. And why is that? Well, these are all of the guidelines that came out for the infant feeding guidance. So in the 1960s, most people were introducing solids by 4 months. In the 1970s, it was between 4 and 6 months alongside breastfeeding. Then in the 1999, this advice came out where it was said that if families had a history of allergy, that it was recommended to avoid peanut in the maternal diet during pregnancy and breastfeeding and until the infant was at least 3 years old. So that was a big change. Also, in 2001, the World Health Organization recommended exclusive breastfeeding until 6 months of age. So that was a big change in what was happening before. 2005, the Department of Health and the EU recommended exclusive breastfeeding until 6 months of age, solids from 6 months of age, but not before 4 months of age, 17 weeks, and no common allergens before 6 months, and no peanut until over 3 months of age, 3 years of age, sorry. Then, obviously, since then, things changed because of the evidence that actually this was not helping and that peanut allergy was increasing dramatically in this time period. So they then replaced this bit about peanut not being introduced until over 3 years to say no benefit in delaying introduction of common allergens beyond 6 months, but infants with family history of allergies to discuss with GP before giving peanut. So that was in 2009. And then in 2014, the European Academy for Allergy and Clinical Immunology, they recommended exclusive breastfeeding for at least 4 to 6 months and no evidence for avoiding introducing complementary foods, including allergens, from 4 months, irrespective of atopic hereditary. So this obviously moves away from what they were saying before, because they were making no difference between allergenic foods and normal non-allergenic foods, and to do them from 4 to 6 months for both. And also irrespective of atopic hereditary. So even if mum or dad had an allergy, they didn't need to go and speak to their GP before introducing peanut. And then finally, this is from 2018, the BSACI and the various committees for the Department of Health recommended early introduction of peanut and egg for infants at high risk from 4 months when the baby is ready and from around 6 months for all infants. Okay, so things have changed really from where they were in the 1960s, going completely the opposite direction, and now we've gone back to where we were around the 1960s or 1970s. So what happened? I think I mentioned that peanut allergy went up during the period of time when they were advising to avoid peanut for the first 3 years of life. So you can see here, peanut allergy in 1997 was 0.4% and went up to 0.8% and then 1.4% by 2008, when this guidance was at its peak. Peanut allergy also increased similarly. So what they say now, and this is from Start for Life. So foods containing allergens can be introduced from around 6 months of age, one at a time in small amounts, so you can spot any reaction. Foods containing allergens can be introduced from around 6 months as part of your baby's diet, just like any other foods. So no need to wait until the child's 7 or 8 or 9 months to introduce foods containing allergens. In fact, doing that may be harmful. Once tolerated, these foods containing allergens need to form part of the infant's usual diet. What I do see in my clinic, unfortunately, is that a lot of parents say, okay, I'm going to give my baby some peanut butter at 6 months. Right, I've done it. That's done. I don't need to do it anymore. And unfortunately, that actually could increase the risk of the child developing peanut allergy. So the child has to have peanut and egg in particular introduced into the diet and continued. So continued every week, as I said, 1 egg per week, and a minimum and 1 heaped teaspoon of peanut butter mixed with foods as a minimum. If you don't do this, this could increase the subsequent risk of food allergy, because then the food is in the home and there's more chance of environmental exposure to that food. So the government has also said delaying introduction of peanut and hen's egg beyond 6 to 12 months may increase the risk of developing allergy to these foods. So delaying introduction of these foods is not recommended. And then families of infants with a history of early onset eczema or suspected food allergy may wish to seek medical advice before. Okay, so this is the group where potentially earlier introduction of these foods may be helpful, or potentially testing may be helpful. So this is available online. It's a parent's booklet that you can access from the British Society for Allergy and Clinical Immunology, which is also endorsed by the Association of Dietitians. So the UK Health Department advises exclusive breastfeeding until around 6 months of age, and to continue breastfeeding throughout the first year. So I wholeheartedly support that. Now, children who have a known risk factor for food allergy, this means eczema or existing food allergy in your baby, are considered to be high risk. So you need to avoid any foods that the child is known to be allergic to. So that's the high risk group. Then there's the group with infants with a household member with food allergy. And I know there was a question about that. And then there are those with no risk for food allergy. So if you have a family member with a food allergy, it doesn't necessarily mean that your child is going to also have a food allergy if they don't have eczema. It's all about the eczema. So if your baby has lovely skin, no eczema, then when the baby is ready, introduce solid foods at around 6 months of age, but not before 4 months. And you include peanut and egg and other foods that are eaten as part of the family's normal diet. So that is for both those with no risk factors and those that have a household member with food allergy. However, if you are in the high risk group with eczema or an existing food allergy, they recommend when the baby is ready to consider introducing solid foods, and then to include cooked egg and then peanut, smooth peanut butter mixed with vegetables from 4 months of age, followed by other allergenic foods. Now, it says here that allergy tests can help identify individual infants at higher risk, but unfortunately the situation in the UK in terms of getting allergy testing is very, very challenging. And so they recommend not delaying introduction of common allergenic foods before 12 months of age, even if you can't get testing. So what do you do if you give your child peanut butter mixed with sweet potato or breast milk or whatever it is that you're mixing it with, and they develop an immediate reaction? So what are immediate type food reactions? They typically happen within 30 minutes of eating the food, and most of the time they will be mild to moderate symptoms in this age group. So they could be swollen lips, face or eyes, an itchy skin rash such as hives or urticaria, or there could be some abdominal pain and vomiting. Very rarely in this age group do you get anaphylaxis. Now, anaphylaxis can include airway problems, swollen tongue, persistent cough or a hoarse cry, breathing problems such as difficulty or noisy breathing or wheezing, or consciousness issues, going pale or floppy, unresponsive or unconscious. And the risk for this is estimated to be 1 to 2 per 1,000 babies at high risk. So the risk is small. Obviously, if this was to happen, you would stop giving the food. You would, if there were anaphylactic symptoms, call 999, say the word anaphylaxis to become a category 1. And then you would be recommended to seek medical advice, such as your GP. Then there are other types of allergic reactions that can occur, like delayed type food allergic reactions. So these can occur hours after the food that you've given your baby. So these could be some stomach pains, some worsening vomiting or reflux. The child can start to refuse the food or develop a food aversion. They could have some loose, frequent stools or constipation, or they could have some skin symptoms like skin reddening or itching over the body or worsening eczema. Now, these foods reactions are not dangerous reactions. They're obviously not very nice for the baby, but they are not going to trigger anaphylaxis. So they're not dangerous in that way. But you should stop the trigger food and symptoms should resolve after a few days. And if the symptoms weren't very severe, you can consider trying the food again 1 to 2 weeks later at home. But if the symptoms recur or they are severe, then it's recommended that you seek medical advice. Right, now I'm going to move on to my favorite part of the presentation, which is all about diet diversity and allergy prevention, because I'm all about fruits and vegetables, love fruits and vegetables. So this was a study that was done in Europe, huge study called the Pasteur study. They showed that higher dietary diversity during infancy reduced both food allergy and asthma. So the food diversity score within the first year of life, which means essentially the number of different foods that that child was exposed to, was able to reduce asthma by up to 6 years and food allergy up to 6 years. And you can see there was a big reduction in both of these. And then after that, this was done in a large study in the UK, in the Isle of Wight, with 900 children. And they showed that the children who have foods introduced by 6 months of age, so any food, be that root vegetables, etc., fruits and vegetables, per food introduced by 6 months of age, there was an 11% reduction in food allergy over 10 years. So that's really impressive. Then, if we look at the number of food allergens introduced by 12 months of age, for each food allergen introduced, there was a 33% reduction in food allergy. So this is really powerful data to tell patients and also for families to know about. So how do we do this in practice? The first thing is that the baby needs to be ready for solids. Now, one of the things I always tell my parents in clinic is that they don't need to be able to sit without support in a high chair. As long as they have head control and they're able to sit with support in a high chair, so with towels or with something to support their back, then they are ready, as long as a few other things are in place. So they do need to be able to hold their head steady. They do need to open their mouth when offered food on a spoon. And they do need to be able to remove foods from a spoon and swallow it rather than spit it back out. Now, obviously from self-feeding from 6 to 8 months, which is what happens with baby-led weaning, they need to be able to reach out, grab the food or toy and put it in their mouth. So they need to have the right eye, hand and mouth coordination to do that. But before 6 months of age, you would not be doing baby-led weaning because they would not be able to coordinate that. And so before 6 months of age, it does need to be pureed, smooth pureed food in a spoon. Okay, so what other considerations when first starting solids? So I generally don't recommend introducing a food allergen right at the beginning as the first food. So don't give peanut butter mixed with breast milk as the very first food, because you want to have some other sort of simple foods. I like particularly root vegetables to get the child onto initially. Because if you give peanut and there's some kind of thing like gagging or vomiting or coughing, you might think that's an allergic reaction. Because sometimes the first time a baby has solids in their mouth, they don't really know what to do with them because it's the first time it's happened. And also then once you've got sweet potato or butternut squash or something like that that you know is fine in the diet, then these are really nice foods that you could mix your hen's egg pureed or peanut butter into. Okay, so what about introducing foods containing allergens? How can you do that? So generally it's one at a time. So you introduce each new allergen one at a time, but you don't have to do it over 3 days unless you're worried about a delayed allergy. So 1 allergen a day is fine. Generally, it's better to do it when the baby is well, when the eczema isn't all flared up, particularly around the mouth, because then they can have irritant reactions around the mouth. And it's better to introduce it earlier in the day so that you can keep an eye on the baby. So start small, start with the tip of a teaspoon and then build up to 1/4 teaspoon and then double that amount until you reach an age-appropriate portion. And you increase this slowly. This is very important. So once you have successfully introduced that food into the child's diet, you need to continue to give them the food regularly as part of their diet. So generally at least twice a week to maintain the tolerance and prevent food allergy. And initially, especially with egg, it might be that the child doesn't really want to eat it. So that's fine. You just put it to one side and you try it on another day. And it's important to go at your baby's pace. You continue with lots of other different vegetables, fruits, cereals, and iron-rich foods alongside egg and peanut. So what to do with regards to egg? They need to be lion stamped eggs. They need to be pureed. So it's quite difficult to puree egg. So you do need to add either water, which would be cooled and boiled water before 6 months of age. Well, boiled and then cooled, sorry. And then either express breast milk or the usual infant formula. So you can then mix that to the chopped hard-boiled egg and puree that. Then you can mix that with sweet fruit or vegetables or yogurt or baby cereals. When they're a bit older, you can then offer chopped or mashed egg, which you can then even later try a soft-boiled egg. And you're aiming for 1 egg per week, and you maintain consumption for 5 years. This is just a little bit more information about what it looks like. So this is your hard-boiled egg for 12 minutes. You cut it into 3 pieces. Then you use that as the basis for blending. And then you can see here how thin the egg is when you eventually give it to your baby. And this is the doses: tip of the spoon, 1/8 of a spoon, 1/4 teaspoon, 1/2 teaspoon, 1 teaspoon of egg. So what about peanut? So how do you get peanut into your baby's diet? As I said before, the minimum amount is 1 heaped teaspoon of smooth peanut butter per week. This is the same as 2 baby spoons. However, you must thin that teaspoon, that heaped teaspoon of smooth peanut butter, with warm, previously boiled and cooled water, express breast milk, or the usual infant formula. And again, very important to maintain this consumption every week for 5 years. There are other foods that you may wish to introduce into your child's diet, especially if they are part of your diet. So it's already in the family diet. That's tree nuts. So cashew and walnut are the most common tree nut allergies, for example. Cow's milk, wheat, seeds, such as sesame seed in hummus or tahini paste, and fish. Again, it's very important to give age-appropriate foods, because you must never give whole chops or coarsely chopped up nuts to children under 5 years of age. Okay, so what are the challenges with early introduction? So what can happen sometimes is that the infant refuses the food, and then the parents can feel a bit defeated, and they worry about their child having an aversion to that food, or they worry that perhaps their child's just not ready yet. Then there are concerns about perceived reactions. The thing I see most commonly in my clinic is that the child develops a little red rash around the mouth, not hives, but just a bit of redness because they have eczema there. And so it irritates the mouth. That's particularly the case with things like tomato and aubergine. And then practical problems. So it's quite challenging to do this, and batch cooking alongside everything else that you're having to do for mums and dads can be very challenging. So what are the considerations for early food allergen introduction? Now, some children, if they have some developmental delay, may not have the oromotor skills to manage solids before 6 months. So it's always about your child. You need to assess your child. So as I mentioned here, some children who were born premature or who have some developmental delay, they may need to wait until they're ready to do this. Now, the other concern is that obviously if we're starting to tell parents which foods and how much to give, that it somehow medicalizes the natural process of solid food introduction. We don't want to take away the joy that is introducing all this wonderful variety of different foods for that child to take on board. So I think it's really important that we still maintain that happy part of what is introducing solids. The other thing is that obviously there are a wide variety of cultures in the UK, and it may be that hen's egg and peanut butter are really not part of their diet. And how can you think about potentially other ways to introduce that, such as peanut soup, which may be more generally consumed in, for example, African cultures rather than peanut butter. Again, as I mentioned, because it's 1 egg per week and it's at least a heaped teaspoon of peanut butter per week, it does potentially increase the pressure on parents to achieve a specific portion. So it's very important to take that on board when I'm giving advice to parents. The next slide is obviously if mum or dad has a peanut allergy, it's quite difficult to get the baby to introduce peanut, because who's going to do it? Obviously, if they have a sibling that is 1 or 2 years older than them and has a peanut allergy, for example, how are you going to keep those two separate? So in that situation, what I usually recommend is that the family either, make a commitment to doing it regularly and find a way that, for example, the older child might be at nursery when it happens, or, for example, the other parent gives that peanut to the child. Or if they decide that that's just not feasible, I just tell them to just keep that food, keep especially peanut out of the house if the child has got eczema, because you don't want environmental exposure through the skin. So those are the 2 options that I recommend. Now, misinterpretation can occur, and I have seen this, that parents think, oh, I can just have egg and then breastfeed, and that is going to be enough to protect my child from developing egg allergy, and unfortunately it's not. So the amount of hen's egg and peanut and milk and other foods, allergens through breast milk, is very, very small. In some very sensitive children, it can lead to some issues like delayed food allergies, but it is not enough to prevent food allergy. Then I mentioned already concerns regarding eczema flares due to the allergens. And generally what I recommend for all my patients that have eczema is that they use an ointment around the face before they give their child solids to prevent these irritant reactions, but not putting a hand inside the pot, because otherwise that gets contaminated with bacteria. Just to use a clean spoon. Baby-led weaning. So I'm all for baby-led weaning, but from 6-7 months, when the child is ready and can do it properly. Under 6 months of age, they just can't do it. They don't have the coordination, so it has to be smooth foods that are pureed and on a spoon. If you want to do baby-led weaning afterwards, then that's fine, but it's not ideal for food allergens. If you remember what I said about food on the skin is not good, whereas food in the gut is good. If your child, especially if your child has a lot of eczema on their face, you really don't want peanut butter all over their face. So better in that situation to continue with spoon for the allergens, but do baby-led weaning for everything else, if you want to. Going on holiday, I've seen quite a few people go on holiday and just stop giving the food allergens. So gaps in routine can be tricky. It's important to maintain the introduction of these foods. And then unfortunately, when that does happen, when there's a gap, sometimes when they reintroduce the food again, if the child has eczema, they can develop new allergies that the child didn't have before. So to summarize, complementary feeding. Introduce solids at around 6 months of age, not before 4 months or 17 weeks. Introduce vegetables, iron-rich proteins, fruits and cereals as part of first foods. In high-risk infants, consider the introduction of peanut and egg when the baby is ready from 4 months as thinned down, smooth purees. Progress to more textured food from 6 months, including finger foods. Obviously, vitamin D supplementation according to the government guidelines. If the child is being breastfed, they need to be on vitamin D supplementation and avoid sugar and salt. So my take-home messages. So children become allergic through the skin. Avoid using oils containing food on the skin until your baby is eating and tolerating that food. If you need to use some cream for a massage, just use a proper eczema cream, and that's fine. But do wash your hands before applying creams to your baby's skin, especially if you've just eaten a food like peanut. If your child does have eczema or dry skin, make sure that you treat it well. Make sure that it's being properly addressed and managed. Strategies to prevent food allergy. So we know from now many studies, I talked about the Leap and Eat study, but these studies have also been done all across the US and Europe and Australia, that early introduction of peanut and egg is effective in preventing these food allergies. But it only works for peanut and egg. So giving your child peanut regularly is not going to do anything about preventing them from developing cashew nut allergy. So if you eat a lot of cashew nuts at home, it is also important to introduce that baby into eating smooth cashew nut butter as well. And there is a narrow window of opportunity to prevent food allergy, especially if the child has eczema or other food allergies. So you want to be getting these foods into the diet early. Infant feeding guidelines. So if your child has no eczema or dry skin, it is fine to introduce food allergens around 6 months of age, but please don't wait until they're 8 or 9 or 10 or 11 months old. If your child has eczema or another food allergy, consider introducing solids from 17 weeks of age, as with, for example, vegetables, and then introducing smooth peanut butter and hen's egg, again, pureed in a way that's tolerable for the child. So there is a lot of support on Allergy UK, which is both for low and high risk groups, so you can access that. And then these are some resources. So for all children, this resource at Start for Life Weaning from the British Dietetic Association, Complementary Weaning, the Allergy Academy also has a lot of great information. Resources for children with eczema or who already have a food allergy. So these are for children that are at higher risk of developing other food allergies. So you have the Allergy UK support pack from the British Society of Allergy and Clinical Immunology. This is from Australia. They have some great things there. And this is another Australian website that's very, very helpful. So that's the end of my presentation. This is just a final slide to provide my contact details if you wish to book in with me at the Portland Hospital or at Wimpole Street with ENT for Kids. My website is Children's Allergy Doctors, and this is my email and phone number. And for NHS referrals, you need to speak to your GP to refer to your local allergy services. And thank you very much for your attention. Very happy to take questions now.
Thank you, Helen. That was amazing. Incredibly thorough, and yeah, it provided all of the information. And my own son is actually treated under the Evelina, so yeah, lots of what you were talking about is what I've learned along the way with his cashew allergy. So it definitely does work. All of the things that you were saying about introducing them and maintaining the tolerance and things like that. We, as you can probably guess, we had lots of questions. You actually covered, I would say, almost all of them within the presentation, but there are just a few things that I thought I'd raise just to get some clarification. You mentioned aubergine creating and tomatoes creating a rash around the mouth, and somebody asked, she'd read that this was because it's high in histamines. Can you elaborate on that a little?
Yes, so essentially that's right. They're called vasoactive amines, one of which are histamines. But yes, they cause irritant reactions, particularly if the skin is broken. And so that's why I recommend making sure that the eczema on the face is treated, but also using an ointment to protect the skin barrier from those vasoactive amines. Yeah.
And that's different to a food allergy.
Yeah, that's an irritant reaction, not an allergic reaction.
Perfect. A little bit about testing, because a lot of parents are often keen to get their baby tested if they're at high risk, or they may have already experienced an allergy or a suspected reaction, and wondering what age they can get allergy testing from. Obviously, this would be quite tricky, perhaps on the NHS at the moment, but if maybe they wanted to choose to see someone private, what are their options?
Well, you can do skin prick tests at any age. So I see children even down to 6 weeks of age doing skin prick testing where the family are concerned about exposure to allergens through breast milk or cow's milk protein allergy. I find that the most, the helpful time to do skin prick testing is once the child has just started on solids. So once they've, done a few of those root vegetables, if they're high risk, then doing some skin prick testing will reassure the parents to know that their child does not have a food allergy to egg or peanut or sesame or cow's milk before they introduce it. And I find that that's very helpful then to just, get them in as quickly as possible. So Monday, cow's milk, Tuesday, sesame, Wednesday, peanut, in small doses, obviously, and building up, but just ramping it up so that it goes very quickly, because otherwise it may be more slow. But yes, there's no age cutoff in terms of when you can do skin prick testing or IgE testing on bloods.
Perfect. And then obviously we've had lots of questions about cow's milk allergy, and babies who were put onto prescription milk, or maybe mum, breastfeeding parent, is actually excluding dairy from their diet, and they're unsure what to do when it comes to weaning, because it's not been such an apparent reaction, maybe more of a non-IgE reaction.
Yeah. So there's some great advice on that on the Allergy UK website. There's one particularly about weaning your child onto solids that have a cow's milk allergy. There's various things you need to think about. You need to think about calcium, vitamin D, iodine. So those are all the things you need to think about. There's some great guidelines from the International Management of Allergy in Primary Care, so IMAP guidelines. Generally, if the child doesn't have eczema or dry skin, they're unlikely to change from a delayed cow's milk allergy to an immediate cow's milk allergy over the space of the first year. So parents can try, little bits of cow's milk here and there to see if it's tolerated by the child. I always think cow's milk yogurt is the best thing to use, natural cow's milk yogurt. If the child does have eczema and has avoided cow's milk for a long time, then either you could get some allergy testing to see if the child has developed an immediate allergy around 10 to 12 months of age, which is most babies outgrow their delayed milk allergy at that point. Or if you can't get access to that, then obviously you just need to be very cautious at home and just give very, very small doses. And there is the milk ladder that they use for the reintroduction of cow's milk into the diet, where under 12 months of age is a bit tricky because it starts off with biscuits. But yeah, the pancakes are, muffins and pancakes that you can always puree and, mix with other foods. It is an option, and you build up that. And those resources are readily available online.
I know the milk ladder and the egg ladder very well. I've used them extensively. Fantastic. I think that's everything. It was, like I say, very, very thorough. We will point people into your direction and to all of those other fabulous resources that you've shared with us as well. So thank you so much for your time, and enjoy the rest of your day.
Thank you. You too. All the best.
Bye.
Bye. Bye.